night and welcome to Doctors on Call. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'll be your host for our program tonight on diabetes. We'll be glad to take your questions on diagnosis, complications, and treatment of diabetes. The success of this program is very dependent on you, the viewer. Please take a moment to call in your questions and we'll do our best to answer them. The phone numbers to call are at the bottom of your screen. Our panelists this evening include Dr. Dave Hutchinson, a family medicine physician with St. Luke's Lester River Clinic in Duluth. Dr. Ken Ripp, a family physician with the Raiter Clinic in Cloquet. And Dr. Michael Slag, an endocrinologist with Essentia Health Duluth Clinic. Our medical students answering phones tonight are Ricky Bender of Northholm, Minnesota, Spencer Locke from Madison, Wisconsin, and Alyssa Wojciechowska from Perham, Minnesota. And now on to tonight's program on diabetes. Well, Dr. Hutchinson, a family physician, you must see a lot of diabetic patients. Is that correct?
I was thinking earlier today about the show and realizing, you know, in adult medicine, it's probably our most common diagnosis or medical problem that we help take care of, yes. I heard some statistics the other day that by the year 2020, worldwide, over 550 million people will be affected by some type of diabetes, approaching 20% of our adult population in the States. It's a huge, huge issue.
Dr. Ripp, maybe we should just get back to basics here. Can you tell us what diabetes is and how do you diagnose it?
There's two types of diabetes. Type 1 diabetes, or the old juvenile diabetes, when the pancreas just sort of stops making insulin, and those people are insulin dependent. But the majority of the diabetics we see are type 2 diabetics, where it's a combination of their pancreas can no longer keep up with production and their body is so resistant to insulin that they can't really use it to get sugar into the cells, so their blood sugar goes up. The pancreas in people with type 2 is actually working really hard. It just can't keep up with the demand.
So Dr. Slag, do you end up seeing all the diabetic patients, or are there certain ones that filter your way?
Well, diabetes, as you've heard, is very, very common, and there are not enough endocrinology specialists and maybe not even enough primary care specialists to deliver all of the care. So diabetes has become something that really we refer to as a team sport. Diabetes is complicated because not only does it require the correct diagnosis, but it requires education, it requires lifestyle changes, and those things need to be done ongoing. So there's no single physician even who can take care of all of the diabetes, and most of us depend on a team of registered dietitians, of nurse educators who are certified in diabetes care, and it's a team between the primary care and the specialists. So the answer is no, we can't see them all, but we see the hard ones. And so the good thing is that there's a big team out there working and filtering and allowing people to be seen at the right place. Primary care individuals like you guys are able to take care of probably 99% of the patients.
If I could add to that, Dr. Johns, for sure, it's too big a problem for just one subset specialty to take care of. There have been studies actually that showed wonderful and equal outcomes in diabetic patients taken care of by nurse practitioners, physician's assistants, primary care physicians, and endocrinologists. What seems to be really important is that the office have an organized academic approach to setting treatment goals and to have adequate time with patients for their visits, to have adequate time between care providers and patients. One problem I feel we run into in primary care is that we often in the context of a 15 or 20-minute visit end up feeling like we need to take care of 4 or 5 or 6 problems at a time. And that can be a problem. We need dedicated visits to help take care of diabetes adequately.
Good point.
Yeah.
Now, when you diagnose a patient with diabetes, do they usually come in with symptoms, or a lot of the diagnoses just happen on the basis of blood sugar? Or?
So many type 1 patients, their initial diagnosis, people who aren't making enough insulin, who are insulin deficient, can be diagnosed on the basis of symptoms. they might notice a remarkable increase in thirst or volume or frequency of urination, or an unusual hunger with weight loss even though they're eating more. Those only represent less than 5% of diabetic patients. 95% of people with diabetes have type 2 or insulin-resistant type diabetes, as Dr. Ripp explained. And those people usually have no symptoms, and we find them on the basis of screening for them or out of suspicion.
And Dr. Ripp, maybe I can ask you, why would you be suspicious of a patient that they might have diabetes? I mean, is there something in their history or family history? Or
Family history can be a big factor. If people in your family have diabetes, then you are definitely at risk. If you are overweight, that's a risk factor. And so we try and screen fairly regularly just the general population with a fasting blood sugar is an easy, quick screen. It's very inexpensive, and it's a quick way to screen. So people who are at risk and who are overweight are probably my biggest targets. And as you get older, your risk goes up. So if you are 55, if you're 65, if you're carrying that extra weight all those years, that's just extra work for your pancreas over the years, and the pancreas begins just to not be able to meet the demand anymore. And so that's when we see it.
I just should remind our viewers that for local questions, for local callers, it's 788-2844, and for long distance callers, which is toll free, area code 877-307-8762. So please call in. There's a lot of good questions. We have a few already. Here's a question for Dr. Slag. I guess you're next up. A caller from Duluth wants to know, how does gastric bypass improve the body's insulin response?
That's an excellent question. Most people years ago thought that the gastric bypass resulted in improvement by actual having weight loss. But studies have shown that you actually start to have improved glucose tolerance within hours after having the gastric bypass.
That's interesting.
And one of the things, the research that's coming out of this, is that we know that there are all kinds of hormones that work locally from the intestine, and that changing the flow of food or nutrients through the bowel is actually changing the signals that are being transmitted into our liver and to our pancreas. And it's becoming apparent that it's those changes in those local hormones that are circulating in our bowels and near the liver and the pancreas that are improving that. So weight loss helps by reducing the insulin resistance over time, but just changing the local flow of nutrients and hormones seems to have a very rapid change after gastric bypass.
Is there a way to do that without the bypass?
Well, that's where the research is going, because if we can figure out which signals, whether it's a protein substance or a local hormone, then it's conceivable that the pharmaceutical industry will actually try to build such a substance so that we can actually get the benefit of the gastric bypass in terms of glucose control without the gastric bypass, which they're great operations, but they do carry risk.
And big complications. We're realizing that it's not just the pancreas that's involved in helping to control blood sugars. It's a very complex set of hormonal interactions, and the pancreas and the stomach and the small intestine and the liver and muscle tissue and fatty tissue are all involved with that. It's very complicated. And for sure, pharmaceutical companies are targeting multiple neurohormonal sites to try to deliver medications to various spots in that control process.
Thank you, Dr. Hutchinson. We have a caller from Duluth, and this is another common question that I get. This patient's A1C was 6.3, and they've exercised a lot, which is great, and now it's down to 5.3. Is that person still diabetic?
That's a hard question. For sure, that person's blood sugars are normal. It's a little bit like asking, it can be analogous to asking if a person isn't drinking anymore, are they still alcoholic if they were dependent on alcohol? We tend to think of people as being prone to elevated blood sugars and needing monitoring and treatment, or not. That person still needs monitoring and treatment and careful attention to lifestyle modification. So in one paradigm, you could think of them as still diabetic. In that person's mind, they should feel extremely successful and proud that they've dropped their A1C to 5.3% and have normal blood sugars. They're fully controlling their blood sugars.
Yes, that's
How's that for
actually-
evading the question?
No, that's
Well, I
pretty-
agree, though, but I think you use the words at the end, controlled or uncontrolled, because that's really the concept. It's you've got diabetes, and you either have it controlled, you're on top of it, it's not on top of you, or it's the other way around. And so that person, if they regained the weight, or they changed their practices, or they aged, as you
Yep.
mentioned, all of those things could cause it to rise up again. So you wouldn't stop monitoring that.
Right.
You would just maybe monitor it less.
And
here-
so we think of surgery, some people think of surgery as curing diabetes versus not. It doesn't really, it's just another way of, in complicated patients, controlling blood sugar. Yeah.
And that another question, a caller from Chisholm calls in and says, can you reverse type 2 diabetes with weight loss and exercise? And that goes along with the same discussion we just had. Depends what you call reverse, you know.
Well, the basics for every individual, whether you have diabetes or not, we always look at healthy lifestyles. And the healthy lifestyle includes eating appropriately, eating the right foods in the right amounts, and being physically active. And so I talk to a lot of people with a lot of chronic diseases, and my statements is that you can have a chronic disease and be as well as you can, doing all of the right things. It's going to be a better version of that chronic disease than it would be if you weren't doing those things. And so I think control or uncontrolled, those basics of lifestyle modification, eating healthy, being active, avoiding the things that cause risk. One of the things we haven't talked about so far is what's the big deal about high blood sugar? Having diabetes causes heart disease, leads to strokes, leads to kidney failure. And so we want people to do all of those things that reduce those risks, such as avoid tobacco, being physically active, eating healthy.
And Dr. Ripp, there's a question here. For a caller from Drummond, Wisconsin, would like to know what treatments or therapies are available for neuropathies, which is one of the complications of diabetes.
Once you have diabetic neuropathy, we don't have anything to really reverse that. There are some now medicines that are new that help lessen the pain. It is extremely painful, and that's why we try and diagnose our diabetics early, keep them under tight control to hopefully ever avoid them getting neuropathy, because that's a bad complication. There are different medicines that work at the nerves to try and lessen that signal to the brain. It doesn't change the neuropathy, but it does lessen the sensation of it. And there's a long list of medicines that your doctor can try to help that. So it's something that we can control the symptom, but once you have it, we can't reverse it. Now, it's not to say throw in the towel, I'm not checking my blood sugar, I'm not going to take care of myself anymore. No, it's time to redouble your efforts, make sure you're doing the best you can to prevent any further damage.
Thank you. Dr. Slag, here's a caller from Duluth would like to know, is there any link between pancreatic cancer and diabetes?
That's a complicated question. Directly, the only way that pancreatic cancer causes diabetes is if the pancreatic cancer is so extensive that it replaces the tissues or the cells that make insulin from the pancreas. Right. There are other hormones, glucagon is one, that are also one of these hormones that help regulate blood sugars, and so that could be damaged. The other way around is there are some of the medicines that are being used that in animals anyway have had some risk of maybe causing pancreatic cancer, and so that's kind of a roundabout answer.
So are diabetics more prone to pancreatic cancer then?
They might be. And the problem, and the reason I'm kind of shuffling on that answer is the data is not very conclusive, but there are some individuals who think there may be a higher incidence.
Sure.
If I could add a little to that, there seems to be an increased incidence of some other cancers in diabetic patients as well, including colorectal cancer, liver cancer, stomach cancer, uterine cancer. And it seems like and I read the same thing, that there isn't a direct causative relationship established between diabetes and contributing to the risk of that cancer. What it seems like is most of that associated risk has to do with the fact that most diabetic patients, most of whom are type 2, are heavy. And being heavy or obese is a risk factor for many of those cancers.
The diabetes is a challenge to your immune system, and your immune system is critical in searching the body and destroying any abnormal tissue before it becomes cancer. And if the sugars are high, the immune system is busy doing other things, and it can allow a cancer to start and not take care of it.
Dr. Hutchinson, Here's a good question. A caller from Duluth would like to know if this patient is now taking insulin, does that mean he's a type 1 diabetic?
So I think that's an important question. Absolutely not. No, insulin is one treatment for diabetes. Insulin is our body's primary hormone, which comes from the pancreas to help lower blood sugars through several physiologic mechanisms. And in type 1 diabetes, insulin treatment is very important because our body doesn't produce insulin. In type 2 diabetes, using insulin is still one option for treatment to help control blood sugars.
Dr. Ripp, here's a question, and this is another common thing related to diabetes. A caller from Duluth was told by her doctor that she's pre-diabetic. And how do you know if a patient's pre-diabetic, and what steps can be used to help prevent that from progressing to diabetes?
So pre-diabetes is usually most often found on fasting blood work that is not in the normal range, but does not quite meet the measure of diabetes. And the numbers are 105 to 126. So if you fall in that range, that is considered pre-diabetes. And that is hopefully the signal to say, hey, you really have to get your lifestyle in order. You need to make sure you're exercising regularly, eating right, so that you can prevent you from progressing to diabetes. And so that's the most common way. Sometimes there's more sophisticated testing you can do with drinking sweet stuff and checking your blood work a bunch of times that you could help you with that. But most commonly it's on that fasting blood work that's not quite normal. So we're not going to say you're diabetic yet, but boy, you're getting close.
So what do you tell these patients?
I tell them, really the best thing is actually getting involved with a diabetic educator. Now their insurance may not pay for that because they need to be counseled on what they're eating, when they're eating, their exercise, and really getting them engaged in their health again. So that, because those people, if they lost a little bit of weight, got a little bit fitter, can really reverse that and hopefully, maybe not prevent, but delay it for 10 years or 20 years. Because if you are, let's say you are 40 and you're pre-diabetic, that says that your body is genetically probably a little set up to be diabetic, but you can delay that and maybe forever that diagnosis.
It's kind of a harsh term, isn't it? It implies some degree of inevitability, but becoming diabetic as a pre-diabetic is not an inevitability.
No.
And I like the way most don't. I like the way you framed that. It's a wake-up call. It's a red flag. It's an important message that a person really needs to pay attention to calorie intake and to exercise.
Dr. Slag, a caller from Duluth would like me to address this question to you regarding injectable Victoza. What are the success rates of that?
Well, we alluded to these chemicals and these hormones that are circulating from the bowel to the pancreas to the liver, and they're all talking to each other. It's a very complicated network. And there are medicines called glucagon-like peptides that are one of those kinds of hormones, and medications like that tend to either act as that type of a hormone or inhibit the breakdown of that kind of hormone. And there's different classes of medicines that have that effect. They are effective, they work, they're not necessarily the answer for everybody. They are not usually the first line of treatment in diabetes, though there are some people who think they might be in the future. So it's a medication. I would say with the medicines in diabetes, it used to be many years ago there were 3 or 4 medicines to choose from, and if you knew those 3 or 4, you were good to go. It's not like that anymore. There are many, many medications available. It's sometimes almost like cancer therapy, where you might need 2, 3, or 4 different drugs to attack these different functions that are going on in the body. One to reduce the muscle resistance or the fat cell resistance, one to stimulate the insulin production, one to affect what glucagon is doing in our body. And so that's where working with a team who understands all of those concepts is important, so that you can get that right match of medications.
Thank you. Dr. Hutchinson, speaking of common medications, Metformin is one of the mainstays of type 2 diabetic therapy. A question from a caller from Duluth wonders, is Metformin given for pre-diabetes? And what do you feel as a physician about the use of Metformin in general?
That's a wonderful question. Understand that metformin is one of the first medications we would use if we're going to use a medication in type 2 diabetes, because it's what we call an insulin sensitizer. Remember, the problem in type 2 diabetes is that our body doesn't respond to our natural levels of insulin in a normal way. Metformin helps muscle tissue and liver tissue respond to the insulin signal more properly, so that blood sugar isn't delivering a continual message to the pancreas to pump out more insulin. It's desirable to try to keep the pancreas functioning at normal levels rather than on hyperdrive, because elevated levels of insulin can have its own set of negative consequences. As we become hyperinsulinemic, it becomes harder to lose weight. That makes it harder to exercise. That makes it harder to control our blood
sugars. So is it
sugars.
used for prediabetes then, or is that
Thank you for helping me get there. Sometimes it's used in prediabetes, and that will be in some patients, and that'll be dependent on who the patient is and what they want and how the rest of their health status is. There's some good evidence that using it early, even before people have full-blown diabetes, that can help preserve kidney function and help prevent complications in the kidney from later on more elevated blood sugars. But not everybody needs to start metformin as a pre-diabetic. Lifestyle management, being careful about what you eat, being careful about the calories you take in, being careful about how much carbohydrate you eat, and exercising are the first line of treatment.
Great. Dr. Ripp, a caller from Duluth, we have about 3 or 4 minutes left here. Should treatment be stopped if diabetes is under control?
Well, that's how you got under control. Now, if you achieve good control and your A1Cs are good and your blood sugars are excellent, you work closely with your physician and your team to maybe look at saying, well, maybe we can cut down this medicine or stop this medicine. And so that's great to be able to go off medicine, but just because you reach that number doesn't mean you stop everything, because more than likely it's going to go back up. You work with your physician to say, okay, here's the steps we're going to take. You've achieved all this. Like the woman who lost all that weight,
right.
She could look at maybe reducing some of her medicine, because once you get under good control, the opposite, high sugar is bad, but low blood sugars are very dangerous, especially as you get older. So we want to be careful not to over-treat.
Sure.
So.
Very good point. Here's a question from Bowabic, Dr. Slag. How reliable is the A1C test?
The A1C is a very reliable test. Over the years, they've become more standardized. There's a national standard for comparison. There are some rare exceptions when people have anemia or possibly recently had a blood transfusion or have some rare blood types where the test can be a problem. But in general, it's become a very reliable test. And in fact, it is now considered a test that you can use to diagnose diabetes. So if your A1C is over 6.5%, there's a high chance you have diabetes, and if it's over 5.7 and not quite 6.5, there's a high chance you have prediabetes.
Here's a caller from Duluth just wondering, how often should she check her blood sugars? It sounds like she's a type 2 diabetic taking metformin. Is this something where you should check it once a day, 3 times a day? Varies?
So really the answer to that question is changing recently. There's more evidence that in type 2 diabetes, frequent checking of blood sugars is less important. That really should be patient dependent. Some patients are very motivated to help control their blood sugars by checking it frequently. Some patients don't get as much benefit from that. What's important is that we be able to monitor with adequate doctor-patient visits and establish a pattern of care and recommendations at home that motivate patients to help control their blood sugars.
So, remember, one of my favorite patients he was an accountant. He loved numbers, and he would check his sugars all the time. He did very well.
For sure.
Some
Some
people are really into numbers. He had
Exactly.
spreadsheets
and it helps
and
them.
everything.
Yes.
It's great.
Right.
And finally, I think we're getting near the end here. So a type 2 diabetic calls from Cloquet, and she was wondering, does this mean that she has to cut out all her sugar that she eats, all pastries, all candy, nothing? That real draconian thing?
No, it doesn't mean that at all. It's really eating sensibly and wise. So how many carbohydrates do you need in a day to be healthy? Well, you can make those carbohydrates be sweet potatoes, you can make those carbohydrates be spaghetti, or you can have those carbohydrates be candy bars. It's really a choice of what kind of density do you want? The candy bar isn't going to last very long or fill you up very long, where a more complex carbohydrate, such as might occur in a vegetable, is going to fill you up, it's going to last a little bit longer, and it's going to help you deal with that hunger issue that you have.
Well, thank you. I think we get the impression that in general, diet and exercise are really big, no matter what
Critical.
medications. It really comes down to a lot of that. Yeah.
Good health for everybody.
Great, thank you very much. I want to thank our panelists, Dr. Dave Hutchinson, Dr. Ken Ripp, and Dr. Michael Slag, and our medical students, Ricky Bender, Spencer Locke, and Alyssa Wojciechowska. Next week, please join Dr. Ray Christensen for a program on arthritis, when his panelists will be Dr. Gail Baldwin, Dr. Robert Leff, and Dr. Cynthia Weaver. Thank you for watching, and good night.